thank you very much for your very kind invitation to speak, and particularly to Jim for inviting me back. It's been a real privilege to be part of the International Scientific Advisory Panel for the Healthier Lives program, and I'm really excited to hear progress on it over the next couple of days. I think what you're doing here is immensely important. And just from a perspective of learning, you know, we in the UK are putting in place things like national science challenges to try and be more mission-led. But we're also tackling the same sorts of issues that you are. And we have a worsening problem of health inequality in the UK, widening inequalities. And we have some suggestion that progress in terms of life expectancy has halted. So I think the issues that you're tackling will be very keen to learn about and to learn from your experience. So it's really a great privilege, a pleasure to be here. The title of my talk today, I'm going to talk mostly about type 2 diabetes. And the title is both a suggestion about how we might frame our approach to primary prevention, which Sajeri just indicated, the suggestion that we should be moving upstream. And I think one of my take-home messages today is that we should be doing that, but we should also be enhancing what we do at the individual level as well, a balanced approach. But I guess the second sort of hint in the title that I want to talk about is when you're going upstream, you're pushing against where the water pressure is going. And I want to just conclude today with some thoughts about are we winning this battle? And is there any, are there any signs of hope? So, as Sajeri said, I've been pretty driven in my career, both as a clinician and a public health physician, with this global problem of type 2 diabetes, which doesn't really need any introduction to you. Suffice it to say that we have a growing number of people in the world with this condition, 643 million when last counted, and 80% of them live in low and middle-income countries. Now, by comparative standards, the prevalence of diabetes in the UK, albeit that it's doubled in the last 20 years, is still relatively low. And yet, we can't afford the costs of treating this condition. So it consumes 10% of our NHS budgets, and in a country with relatively well-resourced healthcare system and a high GDP and a relatively low prevalence. You put that in the context of the global problem, and this, to my mind, when I have my clinical hat on, this is dealing with a clinical manifestation of a pathophysiological problem. But when I put my public health hat on, I see this as a challenge to sustainable development. So it's a public health problem that's driven by wider societal problems. And I want to touch today on how we've got to balance the approach we take to prevention with those two perspectives. So I think when we think about prevention, a good place to start is where the evidence is. And the evidence is always seemingly strongest for individual level interventions because it's easy to do randomized controlled trials and it's easy then to meta-analyze them. So we have results like this, which indicate that if you meta-analyze individually focused lifestyle change programs, the summary estimate is they halve reduction in risk. And that's true across all the big trials, including DPP and the Finnish Diabetes Prevention Program and all these other ones. So there isn't really any doubt that such interventions are efficacious in reducing progression from high-risk state to diabetes. The challenge is that what we do in a randomized controlled trial is not the real world. And when we translate findings from these trials to the real world, we have a problem, which is that trials are not really concerned with the reach of the intervention. That's not the problem for a trialist. The trialist wants to recruit people who are going to stay in the trial. Ideally, it wants to recruit people who are at high absolute risk, because that's the best way to have good statistical power in as small a study as possible. So a trial doesn't really care about reach. It doesn't really care about representativeness of risk. It wants to recruit high-risk people. And it does so in a way that in most trials of diabetes, it's got active follow-up. So in other words, instead of just waiting until people become clinically incident cases, we see people frequently and test them frequently. And when you do that in the context of a trial, you increase the incidence rate because you're testing people a lot. So compared to passive follow-up, the incidence rate is high, the absolute risk is obviously high. And then when we come to roll out programs that we know are efficacious in trials, we get this dilution of effect. And because real-world applications tend to not be quite as intensive as in the trial world. So the big question for us when we look at this literature in my head is not to do yet more trials in perfect settings to see if this is efficacious. The big challenge is how do you take that literature and put it into something in the real world and maintain the level of effectiveness that you see in the trials, because there is this big gap, and sometimes that gap is huge. And I want to give you a couple of illustrations from the work in the UK, which give you a sense of how big that gap might be. So we have, with NHS funding in England, the Scots decided to do their own thing, which is their want and their prerogative. They decided not to do this, but the English rolled out a national diabetes program, which looks very much like what you see in the US diabetes prevention program, but it does it in the context of the real world. It's not a research study, it's an actual implementation. And you can see on the left-hand side the mean weight loss in people who stick with the program. Whoops, sorry. The mean weight loss according to how many sessions people completed. And on the right-hand side is the change in HbA1c. Very impressive looking declines of quite a big magnitude, but of course there's a lot of dropout along the way. Not everyone gets referred, not everyone that gets referred turns up, not everyone who turns up sticks with it. So it looks impressive if you look at people who complete, but what is the overall impact? Because is this a situation where you're getting a halving of risk that you see in the trials, or is it something less than that? Well, it'd be nice to do another randomized controlled trial, but when you're doing with real-world implementation, you can't do that. You have to rely on different quasi-experimental methods. I just want to give you two illustrations of this, if I may. So this is a paper actually came out last year, and it's trying to address the question, what's the impact of the prevention program in England? What is this gap between efficacy and effectiveness? But you can see that the title is quite carefully worded, because it's not, don't press that button, Wareham. So it's not trying to actually ask the question directly, what is the impact? But is saying, can you estimate what the impact is on incidence of referral? Because it doesn't know who actually turned up. It knows who got referred. So there's a bit of an inference there. And then it's using a design which is trying to do a matched cohort. So it's looking at people who were referred and then looking at the incidence of diabetes in them. And then it's trying to create a comparison using some matched cohort of people who weren't referred. And put it like this, however hard you try to do that type of matching, you only match for the things that you thought about to the degree that you measured them, and you can't do anything about the things you didn't think about or weren't measured. So there's always residual confounding. So the importance of this paper is not, I think, that it tells you that referral to the program is associated with a reduction in risk, but it tells you something about the magnitude. So if you look at the association between referral and incidence of diabetes, you can see that there isn't a 50% reduction in risk. There's a 20% reduction in risk. So it's much less than you saw in the trials, but it's not nothing. It's 20% reduction in risk. You do that across a big population, that's a big risk reduction. But this is probably the best it could be. And the truth is likely to be much less than that because of this problem of residual confounding. That it's intrinsic to the design, and this is only actually looking at likelihood of referral, not actually turning up and doing the intervention. But it tells us a bit of an upper parameter on the effect size. I think a better type of analysis is this one, which is the National Diabetes Programme was rolled out in 3 waves. So about half of the practices in the UK were in wave 1, and another quarter were in wave 2, and another quarter were in the final wave. And this is a comparison that a group led by McManus wrote in the Lancet Regional Health a year before last, looking at the incidence of diabetes and doing a difference comparison between the practices in wave 1 versus those in the final wave. And the bottom line of this analysis is that there is seemingly a difference between, in this time period after the implementation of the National Diabetes Programme, there is a suggestion that risk is diminished in those practices that were in wave 1, and the estimate is that it's a 6% reduction in risk. So not 50%, not the 20% in the other one, but 6%. Now, is that worth having? It's highly statistically significant, and it's not nothing, but question mark about whether it is going to turn back the tide of diabetes. So it is an important observation, but an important observation about this magnitude of the difference between what you see in trials and what you can expect in the real world. And I think we have to be honest with politicians, particularly about expectations. If we start suggesting that we're going to see in the real world what trials saw, we're going to be sorely, we're going to be wrong. And the second thing is we need to do better research into understanding this gap between effectiveness and efficacy and trying to narrow it, because there are things we could do. So I want to say a few words about enhancing individual level prevention, because it would be, I know that you have a precision medicine element of Healthier Lives, but I think there's an important question about, can we use the wealth of science that we've generated about the etiology of diabetes, genetics, omics, other things? Can we actually use that to inform what some people have called precision prevention? Very challenging proposition, but I think it's probably true to say that our approaches to prevention, both at the societal level, which we'll talk about in a minute, and at the individual level, really haven't taken that underpinning science and really translate it into anything actionable. So it is a question mark about whether it's useful to do. And I wrote a paper about this. I called it precision prevention, or sorry, personalized prevention. Whether you call it precision or individual doesn't really matter, but the effort is to try and say, is there another way in which we can use all the science that we've done to try and do prevention better? Well, one of the things we could do is to predict diabetes better. So at the minute, most intervention studies like the National Diabetes Prevention Programme use HbA1c, essentially. And if you're in the range 42 to 48, pre-diabetes, then you get referral. Just as an aside, it is possible to use glucose measurements to get into the National Diabetes Programme. But I checked recently because I thought, how many people are actually getting in on the basis of having like fasting glucose elevation? The answer is virtually nobody. So there's been this radical shift in the UK away from any measure of glucose informing intervention to HbA1c. It's almost entirely HbA1c driven at the minute. Now, the question mark is, could we do better in terms of risk? Well, we could. We know a lot about genetics. And for many years, people have been saying, well, can't you use genetic predictors to predict diabetes better? So this is a really important paper in 2008 by James Meeks. What James did was compared a simple clinical model, which did include measurement of age, sex, obesity, and a glucose measure. And that got an area under the ROC curve of 0.900. And then he threw all the genetics we knew about in 2008 and changed the third decimal point. So if you can tell the difference between those two lines, you're better than me. I reviewed this paper for the New England Journal. In the first, shouldn't say that, should I? In the first iteration of the paper, they put this was a highly significant difference between 900 and 901. I think I got them to change it to clinically irrelevant, but it's really very small. Now you might say, well, haven't you progressed a load of understanding about genetics since then and made this better? Actually, no. So, because all the top genes were the ones we knew about there in 2008. Everything since has been incremental. It's just added a little bit, but not much. Part of the problem here is when I think we're talking about improving prediction, we tend to not see it in the context of the real world. So at least James here in his paper actually did make a comparison to a simple clinical model, which very few people do, but didn't quite do it in the way that you would do it in clinical practice. So we just wrote a paper, it came out last year, where we tried to look at this in a slightly different way. And if you look at all individuals, a simple risk score that uses information we know about on everybody has a C statistic of 0.76. So not even collecting any information, just using what you know now, you can do really well. So a genetic risk score there by itself doesn't do much. If you took blood and just did a standard set of biomarkers, you do a little bit better. Metabolomics doesn't really add very much. Proteomics does add something. And if you throw on all the omics together over and above a simple risk score, it does pretty well. But if you then look here, the incremental change, a simple score using a measure of HbA1c does 0.82, and you're really, everything after that is slightly small. The problem is that that's assuming that we don't do anything based on the information we get from something like HbA1c. But of course we do. So if you've got an HbA1c that's over 48, you just treat the person, they've got diabetes. If they've got an HbA1c of 42 to 48, you put them into a national diabetes prevention program. So enhancing prediction in the people where HbA1c is above 42, to my mind, not much point, because you're going to act anyway. So what we tried to do was to say, what if you looked in the group of people with HbA1c under 42? And there you see the risk score doesn't do quite so well. Actually, a genetic risk score does quite well. And at the bottom, actually, the best single solution is to do a clinical score plus a genetics. So maybe genetics might help in this subgroup of people where today you're not going to act. So maybe it might help. The challenge is that when we come to think about improving prediction in the real world, we are trying to not predict things like C statistics. We're trying to predict absolute risk. So if on the y-axis of this graph is the cumulative incidence of diabetes, this is in a big population-based study, and this big red line here is people who are not diabetic but whose HbA1c is over 42. So these are the people with pre-diabetes. So we as a society have decided we are going to intervene on these people because their risk is sufficiently high that it means that if we reduce that risk, there'll be a population benefit. And this is the group of people with HbA1c under 42 stratified by the genetic risk. So you can see if these are the people with the lowest genetic risk, very low incidence. This group here have the highest genetic risk, but are still pre-diabetic. So you can, in this group, find a relatively high risk group using genetics. In the end, whether you decide to intervene in this group or not is a question of the magnitude of benefit and how much you're prepared to pay. So we have a program for people whose absolute risk is at this level. This group are about half of that. Now, if the effect of the intervention were the same in this group as in people with prediabetes, it would cost twice as much because the risk is about half. But what if the risk benefit is different? What if they respond differently? So I think there are some important questions to ask, but we've got to try and address them in the context of the real world, not in isolation from that. So I said that our programs are mostly based on HbA1c, that they miss people. So they miss people who've got a normal HbA1c, but the only glycemic abnormality they have is isolated post-challenge hyperglycemia. So the fasting is normal, but the 2-hour is between 7.8 and 11.1, and they have a normal HbA1c. And you might say, that sounds very recherché. What is he talking about? Well, the issue is it's really common. So in our population, 3.5% of people have this, of the normal population. And it's actually thought to be more common in certain populations, particularly South Asians. I don't know what it would be in New Zealand, but it's surprisingly common. And these people have a high incidence of diabetes. They have a high risk of cardiovascular disease and of all-cause mortality. And they are missed by screening programs. So we just do not find them, and they're missing out on potentially beneficial behavioral interventions. Now, what can you do about it? You could do a universal oral glucose tolerance test, but that would be a ludicrous proposition because the problem is not just staff time, it's people's time. You're asking people to take half a day off work to come and have this test. So I think that there are important research questions for the future about how we might try and find these people. And I'll just give you, this isn't the answer, but it's one suggestion is, can different measurements help us identify people with isolated IGT? Can you find them but different ways? So biomics, I largely mean proteomics here. So we did a big study, 11,500 people. The people with prediabetes or diabetes just get on to the intervention. The people with this isolated IGT with a normal level of hemoglobin, if you did a simple test on blood, you could reduce the number needed to screen to find them from 14 to 7. Now, it's not enough to start rolling this out in clinical practice. But to me, what it is trying to focus our attention on things that we're missing now that we could, if we found people in this category, we could get on and reduce risk and potentially have benefit. Okay, so the final part about precision prevention, so finding things that we're missing currently, predicting disease like type 2 diabetes better. Those are two examples. I think the third one is trying to break down a condition like type 2 diabetes into distinct subgroups. It is not one disease. It's one disease label, but it's probably multiple diseases. And this group in Sweden have tried to use different sorts of information in a study based in Botnia to try and divide type 2 diabetes into subcategories: a severe autoimmune group, severe insulin deficient, severe insulin resistant, and classical MODY, and a mild obesity-related and mild age-related subtypes. So you can do this form of cluster analysis. My reading of the literature is it doesn't help very much in telling you what to do because it's not specific enough. So it's an interesting way forward, but I think maybe the better way forward is to think about trying to find subgroups of people, but by better phenotyping. So this is somebody I saw in the clinic who, this is their DEXA scan of their fat distribution. And this is what someone with typical type 2 diabetes would look like. And the person on the left actually was referred up by their GP with a letter that said this person, they paraphrased it. It was essentially they're not trying hard enough. So put the blame on the patient. Actually, that lady had lost 37 kilograms in weight. And I looked on her iPhone, she was averaging 10,000 steps a day. So she was trying her darndest. And she has a form of partial lipodystrophy, not with a known genetic mutation, but she has a relative inability to store fat in the safe areas. So if you look at the distribution of fat, she has no fat. Whoops, I've done it again. The big green button is so tempting. If you look at the person on the right, this person has a lot of subcutaneous fat. The person on the left has almost no fat, particularly in their legs, just relative inability to store fat in a safe place. And the reason for mentioning this is completely hidden, and finding it and giving it a different label certainly would help this person. It would say it's not your fault, despite you're trying your darndest. And maybe in the future, we might get some specific treatments. And this probably has a genetic etiology. So if you look at insulin-resistant genes, they are associated on the right with increased risk of diabetes. But if you look at where the fat is stored, and this is fat in the legs, you can see insulin resistance genes are associated with higher risk of diabetes, but are strongly associated there with having less fat in the legs. So this phenomenon is true for rare, I can see some quizzical looks in the audience, so these people just have a relative inability to store fat in a safe place, which means that if you eat too much, which is pretty much everybody, right, in the positive energy balance, it doesn't get stored in the safe place, you get overspill, and the fat goes to where it's disadvantageous, particularly the viscera and the gut. So this is just a pathophysiological manifestation of what we know about waist-hip ratio, the ratio of your waist to your hips. And most people think the primary defect is storing fat centrally. It's actually not. It's just being relative inability to store it peripherally. So why does this matter? Well, if you compared people who have a definitive genetic condition, those dots in red, and this is a plot of leg mass against the rest of the body, you can see that they have a distribution that puts them in this quadrant. The importance is there are plenty of people walking around in the rest of the community who look like that, who probably have this condition, but it's not diagnosed. And it's not diagnosed because we don't look for it, we don't phenotype our populations right, and to be honest, in the clinic, we sometimes don't take people's trousers off to look at their legs to see how much fat there is. So it's an illustration of better phenotyping, thinking about the condition, trying to subtype diabetes into its different subtypes. And I think this is a way forward for precision prevention. The final one is for precision prevention, is what is the hope for personalized nutrition? We give one recommendation to everybody. Is there any hope for personalization of this? So this is a really good study from Israel, used a whole series of assessments and tried to get to a prediction of postprandial glucose regulation, tried to give personalized recommendations about what people should and should not be eating. And they compared that in terms of its impact on different measures of glucose, with this predictor before and after in red and green on the left, compared to an expert. So they're arguing that the algorithm does as well as a dietitian. Don't worry, dietitians. I don't think you're going to be out of business just yet. But this is suggesting that the algorithm does quite well. But the important thing for this is that a lot of groups around the world stop at that point and essentially flog the idea of personalized nutrition to people and don't go on and evaluate it. And that's because if you're venture capital, dependent, you want to prove yourself right rather than wrong. It's not a very good business to prove that what you're doing isn't working. But scientifically, we've got to set out to evaluate it. So at least this group in Israel did a trial and randomized people to a Mediterranean diet, all this post-prandial trained diet using the algorithm. And it was quite big, and 94 people completed the trial in both arms. And I think it's impressive that they did it. And it's impressive if you look at the HbA1c that the comparison of the Mediterranean diet versus this post-prandial trained diet, that difference in HbA1c is not very big, about 0.1 on the HbA1c scale. It's actually about the same as the diabetes prevention program. So it's actually quite a big effect. Now, to me, the big scientific question for the future is, what do you do with this? Does it mean everybody should get access to this algorithm rather than dietary support? Actually, what the algorithm is predicting is a low-carb diet because the percentage carbohydrate was half in the post-prandial trained diet than the Mediterranean diet. So it's a fancy, expensive way of giving people a low-carb diet. Now, it may be that it's effective not just because it's that recommendation, but because maybe people respond differently to something that looks personalized. So I think it's important, it's good that they did a trial, it's good that they tested it. The big question for the future is, what is the mechanism? Why is this working? Because it might be nothing to do with what the recommendation is. It might be to do with people's perception that it's somehow about them. And that would be an important observation. So I want to move then to think about some research about moving beyond the individual to the population. And as you know, because I've spoken here before, I think this requires serious investment because it's very easy, relatively, to get investment to do the sort of science I've just showed you before, very individually focused, very heavily dependent on technology. It's much harder, but more important, to get research funded to understand what are the major determinants at the societal level of diabetes and what can we do about them. And I just want to, before turning to some specific examples, just want to give you 3 types of research that I think we need to do more of. And the first is about quantifying dose response, because there's been under investment, I think, in trying to understand how much a particular risk factor is related to the outcome. And the example I'd give you is diabetes is about physical activity. So we know from studies like our own, if you take a questionnaire and put people in a category, that it ranges from inactive, moderately active, moderately inactive, rather, moderately active or active, that per category, there is about a 13% reduction in risk of future diabetes. Now, each of those category differences is about equivalent to an extra 20 minutes walking per day. Not, so on average, that would be. So question mark is how much risk are we going to get if everybody in the population could shift by 20 minutes a day, which is not huge. It's beyond, it's within rather the bounds of most people's capability. So you're not suggesting that people in this category should suddenly become active, but even shifting from the inactive to moderately inactive, you predict would give rise to this 13% reduction in risk. Now, one of the challenges is that this type of study is using methods that are quantitative and are related back to some objective assessment of physical activity energy expenditure, but are not measuring it directly. And I think in epidemiology we need to try and quantify this type of association better, because it matters when you translate it into public health recommendations. How much might we expect if people made these small changes? So we managed to do this in the UK Biobank study. So we implemented in 100,000 people a wrist-worn accelerometer that is very easy to use and measure, and was done massively on scale, and can allow you not only to characterize different types of behaviors, but using some algorithms that are open source that have been developed by our group, can actually convert it into physical activity energy expenditure with good validity. So it's objective. And I show this because A, I think it's important, but B, it's what I did in my PhD 30-something years ago, and I did it on a small scale, and I thought I was right then, and it takes 30-something years to come back to it on a big scale to prove yourself right. So I'm sorry if that's a bit vain, but I wanted to show that actually small changes in physical activity were associated with big changes in diabetes risk. So the green line is the risk estimate, comparing different levels of physical activity energy expenditure. That's what on this x-axis. And this is the risk of diabetes relative to this group here. You can see that it's an immensely steep risk. It's really very strong. And it is, it's attenuated if you adjust for obesity, but it's not obliterated. And what it says is that 20 minutes a day walking estimate to give rise to about a 10 to 13% reduction in diabetes risk is about right. And it says that it's true across the whole population. So the public health messaging from this is really clear. Everybody needs to do a little bit more. However they choose to do it, that's their business. But everyone needs to do more. There's no threshold, there's no magic. If you do this level, you're free of diabetes. Just everyone needs to do more. Now that may be blindingly obvious, and maybe it's taken me 35 years to work that out, but I think it's an important public health message. The other thing that our epidemiology can help with is risk the same for everybody? Because all of the epi I've showed you before is assuming we're all the same. So Jerry, when he introduced me, said I've been interested in the interplay between factors like genetics and behavior. So this was an attempt to look at the difference in the risk estimate associated with genetics by different strata. So at the top is the summary overall estimate. So per standard deviation of a genetic risk score, the risk of diabetes goes up by about 40%. Genetics is very strong. But is it the same in all people? Well, you can see, compare men and women, it's absolutely identical. It's not different between people with family history. It's very different for levels of body mass index. And it's very different between waist and age at entry to the study, less so for physical activity and less so for the dietary factors, although these are very imprecisely measured. So what it says is the genetic risk of diabetes is much stronger in people with a BMI under 25, and is much weaker in people with a BMI over 30, the genetic risk. So some people said, this means we should be looking for genetic risk factors for diabetes in the not overweight, because that's the group in which it's strongest, which would be entirely the wrong conclusion, because when we think about intervening in a public health sense, we don't intervene on the basis of relative risk. We intervene on the basis of absolute risk. And if you plot it differently, it's the same data plotted in a different way. Here we're going across, this is groups by genetic risk, low risk, and then this group on the right, the high risk. And then within those genetic strata, these are the people who are obese, in blue the people who are overweight, in red the normal weight. Now, if society deems that that's the level we're going to intervene on, you can see, which is a arbitrary decision point line, right? You can see that everyone who's obese would get the intervention because at the 10-year point, whatever your level of genetic risk, this line crosses this one. So yes, the risk is higher if you're in this high genetic risk, but you're already at high absolute risk, so you should get on and intervene. And if you're not overweight, in fact, if you're normal weight, which is these red lines, it doesn't matter what your genetic risk is, because even in this high genetic risk group, your absolute risk is so low that you're never going to be anywhere near this line. So it's an important message in terms of thinking about these things in absolute risk terms rather than relative. And what this suggests is right now, although there are some statistical significant interactions, none of it is relevant to what we might do for prevention. It says actually the same thing is good for everybody. So the final question about epi into public health is about, I say it's the same for all people within a population. What about across populations? So I've been fortunate. This was a big European study called Interact, which was 10 different European countries, 11,500 incident cases of diabetes out of a population of 500,000. I then led a big project called Interconnect, which was trying to bring data together from around the world and bring data together in a way that is really democratic. So the data doesn't move. You take your analysis to the data rather than the other way around. So it uses what's called a federated meta-analysis. And this is the results, not published yet, but hopefully about to be. So of nearly 2 million participants with 107,000 incident cases from all populations around the world. There are some people who say the only way to meta-analyze data is meta-analyze big studies because small studies are biased. And you need this, there's this thing called 100,000 Club, which is cohorts of 100,000 more. I think that's the wrong way to do it because it studiously excludes people who've got small studies, which tends to be people who are under-resourced. And if you look here, this is trying to look at, is red meat associated with diabetes risk? I know an issue that's important for many countries around the world. These are the Americas, quite a lot of data. This is the Eastern Mediterranean, next to no data. This is Europe, lots of data, next to nothing from South Asia, and quite a bit from the West Pacific and East Asia. And the overall effect size is the bottom. So for a 100 gram per day difference in meat consumption, there's about a 10% increase in risk, wherever you are in the world. So we should all be eating less meat. There's no threshold. There isn't a safe level. Just says everyone should eat less. But what it also says is, we worry about inequalities in health. I worry about it. I also worry about inequalities in health research. So if 80% of the world's people with diabetes live in low middle income countries, we have no data whatsoever from Africa at all. And we have next to nothing from South Asia. So the data is disproportionate to where the problem is. And frankly, I think that's something we should do something about. So it's a really important rallying call to try and redress this problem of inequality in health research data as well, to actually go where the problem is rather than where the data is. But it suggests that reducing red meat consumption, however we might choose to do that, be that by advocacy, fiscal measures, or co-benefits of thinking about it in terms of planetary health as well as personal health, we need to be advocating for lower red meat consumption. So the final bit I want to talk about is what's the process by which we might develop and evaluate population-level interventions? And as you know, this is where we need to take a different perspective, moving beyond thinking about people's individual educational status, perspectives, and beliefs, to thinking much more culturally, seeing people as part of a wider system that's driven by socioeconomic factors, cultural and the environmental conditions. And, you know, Jeffrey Rose wrote this seminal book that, you know, if you haven't read it, you really should, not least because it's co-edited by a colleague of mine, who's probably on commission. What he says is that as an adjunct to high-risk prevention approaches, efforts to shift the population a little bit to the left by making small changes in a lot of people, that's how you accumulate the biggest risk reduction at a population level. And Jeffrey Rose tells you that this is a good idea, but he doesn't tell you how to do it. So for the last 20 years or so, we've had a centre in Cambridge trying to create some evidence base for this, because I think that's what's important. But I'm not going to go through all of that, but what I want to do is try and give you a sense of where the evidence is accumulated and how it's accumulated. So when we think of trials, and I showed you things from trials earlier, we develop an intervention, we do a definitive randomized controlled trial like the DPP, then we put that together in an evidence synthesis, and at the end we present that data to policymakers and they say, yeah, let's fund the English diabetes prevention program. So the policy action is right at the end. But when we're dealing with public health, it's a totally different game. So we can't do that. That does not work for public health. What we do in public health is take some observational evidence, that creates a policy. Somebody then has to take bold and decisive political action, and then you can evaluate it, and eventually you can synthesize it, evidence across populations. So I'm going to give you one example. Focus in the bottom left-hand corner. How do you get from observational evidence to policy action? Well, this is where science meets policy. So, you know, we and others had done quite a lot of literature about consumption of sugar-sweetened beverages, for example, and the risk of type 2 diabetes, showing that it's consistent across all the populations, so quite a big increase in risk for relatively small consumption of sugar-sweetened beverages, and others had shown that it was important for obesity. So how do you get from that to a policy? Well, you have to accumulate the evidence, and you have to accumulate the evidence whatever the political paradigm that you're working in. So some of my colleagues told me there was no point us doing any research on fiscal interventions because no government would countenance it. Okay, so I think that we should do the right research, and whether it then gets implemented or not is another matter. But I don't think current political considerations should colour what research we do. I think that's a very dangerous road to go down. However, what people do in politics is a political process. So in 2014, which was a year before an election in Britain, and it was a very tight election that Cameron won by only about 10 or 11 seats, very tight. There was a parliamentary select committee saying, what should we do about diet and activity in Britain? And I gave some evidence and answered all their questions. And I got to the end of the questioning and I thought, they haven't asked any questions about fiscal interventions. So I said to the chair, are you not going to ask any questions about fiscal interventions like tax? And every single person on the committee just put their head down, tried to ignore me. And the chair was an independent past GP, and she said, that's great, send us in, you know, what your summary of the evidence is. And we did that. And probably much more importantly was at another session, you know, they'd had the sort of rather boring academics from Cambridge, but another session they had Jamie Oliver, who was slightly more passionate about what they ought to do than me, which I think is important, because I didn't tell him what to do. I said, do you want to hear the evidence? And he went a little bit further than that, which is, I've always tried to not get too far beyond the evidence into advocacy. I think that's somebody else's job, but maybe we can talk about that in discussion. Anyway, the following year, in 2016, George Osborne, a Tory right-wing Chancellor of the Exchequer, announced it's not a sugar tax, it's a soft drinks industry levy. And it's, whatever you think, it's really clever politics. So it wasn't a nanny state tax, it was an incentive to industry to reformulate, having agreed that we wanted to reformulate anyway. So for drinks that were more than, I think it was 8 grams per 100 mils, per litre, sorry, of sugar, it was 24p tax. And then there was another level that was 5 to 8, that was about 18p. So two different levels. And the announcement of the tax, which was then going to be implemented in 2018, it was announced in 2016, just the announcement of it with a 2-year warning caused the companies to reformulate. So interesting politics. I know, not wishing to stray into your politics, that you have some challenges. I would say that I was surprised by this. You never know. And we were not put off doing the right research. We were not put off telling politicians what the evidence base was. Whether they choose to pick that up and do anything with it is their business. And we were surprised. No, I've never met anybody in public health in Britain who saw this coming. I mean, some people claim they did, but I don't actually believe it. It was really, so you don't know what might happen is the message. And do the right research, create the right evidence base, and wait. Everything has its time. So what about, is it working? So colleagues of mine, led by Martin White, have then gone to the next bit of this. Can we evaluate this? And you'd like to do a randomized controlled trial, but you can't. It's not that type of intervention. So it needs a natural experiment. And Martin and colleagues have used this type of analysis, looking here. This is sugar consumed per week by household, and you can see that in the higher tier that was already going down, but it's the counterfactual is what it would be without the implementation or the delivery of the intervention of the tax. The observed is lower. So it's reduced consumption in these higher category, higher tier types of drinks, and also in these lower tier drinks as well, quite marked compared to what the counterfactual, what it would have been otherwise. The interesting one is here, this is no levy drinks. It's predominantly milk-based soft drinks. And you can see that actually that goes up. So sugar consumption in these no levy drinks has gone up. But the magnitude of it is dwarfed by the reduction in these high sugar drink types. So yes, this has gone up the wrong way, but overall in the population there's about an 8 gram per household difference per week, which equates to about 3.3 grams per person. So has been a reduction in consumption. Now, I'd love to be able to show you the impact on obesity, but that will probably take a while. But what about some really proximal measures? Well, one of those is dental caries, which is actually the biggest cause of hospital admission in the UK for people aged under 18. It's very surprising. And what Martin and Jean Adams and colleagues showed was that actually, compared to this pre-period with the announcement here of the tax and the implementation here, there's been a reduction in admissions for dental caries. And dental caries very much driven by sugar-sweetened beverage consumption. So a sort of early suggestion that this is having an effect. And what we'd like to do is to be able to go beyond that to say, does this work in all populations, in all jurisdictions, in all different types of tax? So that's an evidence synthesis question. And a group from Otago have done a very nice systematic review in 2019 of the literature as was then, suggesting for a 10% taxation, there was about a 10% reduction in consumption. And this was good, but there's been a massive explosion in the literature about sugar-sweetened beverages. So I think, in due course, it'd be good to come back to that evidence synthesis and say, what do we know now? Because there's, even in 2020, there were nearly 80 papers. So a very exciting indication that this is working. And I use it as an example to show the type of research one needs to do, quasi-experimental, different methods, but also to give a sense that because you've got this juxtaposition between evidence and policy, you have to operate in a slightly different world, which is a bit unpredictable. So the final thing, just wanted to close it, is any of this making any difference? And that's what, the people, I'm driven by the fact I still do a diabetes clinic. And yes, I treat, those people, I treat them individually, but they're a manifestation of that 650 million people around the world. And are things getting better, yes or no? Well, in terms of obesity, one would like to say that, there's been this transition between countries where the obesity prevalence is low, that it goes up, driven by economic development, unfortunately, but that in the most developed countries, maybe we're beginning to see a plateauing of obesity rates. It is true, however, there are no countries where at the overall total population level, they've yet to see that plateauing of obesity levels at the whole population level coming down. Now, it may be that that's a bit of a tall order to do it at the whole population level. And I think this is a very encouraging paper led by my colleague Ken Ong from Cambridge, looking at very young children. And I think that there may be a suggestion that compared to the expectations for the WHO of both the developed and the developing world, in England, there might be at least a plateauing of obesity prevalence in very young children. This spike is all to do with COVID and our lockdown that we had for COVID, which may or may not have been good for COVID, but certainly was not good for obesity prevalence in young children. Fortunately, is some suggestion it's reversed. But maybe the important thing is slight decline in Victoria, but this apparently quite steep decline in New Zealand. And I think what the authors of this suggested was obesity prevalence in young children is very driven by systematic factors to do with childcare, early life interventions, which have been obviously very good in New Zealand, as I understand it, and have been a little bit better in the UK than they were historically. But this might be the first instance where maybe we are turning the corner for obesity prevalence, but we can discuss that. But what about turning the corner for diabetes prevalence? So I put this up at the beginning, the thing that drives me. Of course, if you take a step back, it's absurd to think that we're going to impact in a positive direction on diabetes prevalence, because diabetes prevalence goes up for good reasons as well as bad. Diabetes prevalence goes up if you treat it well and people don't die of complications. Diabetes prevalence goes up if you have a good screening program and you find people early. So we have to be careful about expecting total prevalence to go down. Of course, it'd be nice that it went down eventually, but in the short term, it'll only go down by doing the wrong things. So actually what you need to look at is incidence. And certainly in the UK, if we look at incidence of diabetes, this is data from IQVIA, there's some suggestion between 2008 and the late 2018s of a reduction in incidence, rate of occurrence of new cases, particularly actually in women. Now, the question is whether these are really positive signs, or are they the first signs of spring, or am I just being the victim of wishful thinking? But that maybe is something we need to discuss, because I think in the face of people who want to put forward alternative solutions to these problems, the things I've described are really difficult, they're really long-term, and it's very easy for the people who want to propose a different type of solution to say, and it's not working. Look at the problem. There's still loads of people with diabetes, still lots of obesity about. And I think we need to cautiously find some good news stories and to promote the idea that these are the right strategies, particularly the upstream ones, and that we have to put them in place seriously, and we have to put them in place in a way that gives time for them to have benefit, which will take a long time. So I hope that I've tried to take you on a journey from trials, efficacy, improving those, thinking about the role or otherwise of precision prevention, through to this very important agenda about going upstream and maybe trying to look for signs that this is working so that we can tell a good news story. And with that, I will thank my colleagues at the Institute of Metabolic Science who did all the work that allowed me to stand here and talk, and happy, Sir Jerry, to take questions. Thank you.